Right, so today we're going to talk about the development of the respiratory system. Right, so these are the objectives. So the main objectives, they are going to be you have to understand how the larynx, the trachea, the bronchi, and the bronchus are going to develop, and also understand some embryological bases of congenital trachea and lung disorders. Right, so the respiratory system starts to develop at from week 4. That's a week after folding, um, after folding as well as after granulation, right? So remember when we did the body cavity and we were able to discuss how important it is, the development of the lung in separating of the body cavity. If you remember well, we spoke of the pleuropericardial membranes that will they will start as folds and then they're gonna fuse at the midline due to the ventral, caudal, and lateral growth of the lung. So that's what we want to talk about today. Right. So this you see here, that is going to be your gut tube. Your gut tube is divided into three. You're going to have your gut, right? Your midgut and your hindgut. So the respiratory system, it starts as a diverticulum, what you call a lung bud, or what you call a respiratory diverticulum. So this side is dorsal, this side is ventral, this side is posterior, this side is anterior. So you're going to have um, some what you call retinoic acid. So retinoic acid is going to act on the mesoderm. It's going to act on the endoderm and cause a transcription of TBX4. So the transcription of that factor, it is the one that is going to initiate the budding of the respiratory diverticulum during the fourth week, right? So this is going to be your foregut. This is going to be your respiratory diverticulum. So we have a communication between the foregut that will be opening, that will be open. That is what you call a laryngotracheal opening, right? Very important. And this layer that will be surrounding your foregut is your what? Your splanchnic membrane. Remember your splanchnic membrane or visceral, your splanchnic mesoderm or your visceral mesoderm originating from the lateral plate mesoderm, right? And it is going to surround the endoderm due to caudal and lateral folding of the tube. Now you see splanchnic mesoderm surrounding this. Is it? So, so you can see this is still your what? Your lung bud, right? Developing ventral to the foregut. So, if we cut cross section, so let's cut this will be A, this will be B, this will be C, right? So you can understand that if we cut longitudinally, this is going to be the respiratory ventriculum, this is going to be your foregut. And there's going to be separation between your lung bud and your foregut due to what you call tracheoesophageal fold. So you can see some ridges here that are going to meet to form what you call tracheoesophageal septum. So the tracheoesophageal septum is the septum that is going to separate anteriorly. You're now going to have your trachea and your lung bud. Then posterior, you're going to have your esophagus. So you can now see that the tracheoesophageal septum is completely separated, your laryngotracheal tube and your esophagus. You understand? So ventral to the esophagus or anterior to the esophagus, anatomically, gross anatomically, you understand that there's a trachea. And then posterior to the trachea, you're going to have the esophagus. So that's how the two are related embryologically. So the tracheoesophageal septum divides the foregut into two regions. The ventral, the one that I say, the laryngotracheal tube, to form the larynx, the trachea, the bronchi, and the lungs. Remember? And then dorsal, you're going to have the oropharynx and the esophagus, right? Dorsal, you're going to have the oropharynx and the esophagus. The endotracheal tube opens into the pharynx via the larynx, right? So there's going to be open communication, right, between your trachea and the pharynx via the larynx. Is it? Uh, so, but as we go down, you're going to find that this is going to be your laryngotracheal uh, laryngotracheal tube, right? That is going to give rise to three things, or let me say, okay, it's going to give rise to the larynx, the trachea, the bronchi, and the lung. So that will be ventral. These two will be dorsal. Right. So due to this development, there can be defects in the separation of the lung bud and the esophagus. So these are some of the defects that we are going to talk about here. So disorders of the tracheal and esophageal development. So the tracheoesophageal fistula. So we have tracheoesophageal fistula being the first one. That is incomplete division of the respiratory and esophageal parts. So remember, we want to get here, we need to completely divide these two. If we fail to divide, we're going to have a fistula, which means there's going to be a communication between your esophagus and your trachea. So what do you think happens when there is a communication between your esophagus and trachea? What you call tracheoesophageal fistula. Whatever that is coming into the esophagus will get into your trachea. Especially if a baby is born with a tracheoesophageal fistula, you're going to have that the milk that will be coming down through the esophagus is going to enter the trachea, and this can lead to choking. So if you see a baby choking every time the baby drinks milk, it's more likely to be tracheoesophageal fistula, that the milk is not getting to the stomach, but rather it's getting to your respiratory system. Incomplete fusion of the tracheoesophageal folds causes a defective tracheoesophageal septum. You understand? So if we have a defective tracheoesophageal septum, you're going to have communication between these two. Tracheoesophageal fistula. So the most common of the tracheoesophageal fistula is this one, right? That's the most common. That's the most common. Where you're going to have tracheoesophageal fistula with esophageal atresia, right? So you're going to have a blind pouch of the esophagus, and then you're going to have the trachea having a fistula um, with the trachea having a fistula with the esophagus. You understand? So in this, if in this way, you're going to, for you to understand or to know that the baby has tracheoesophageal fistula with also tracheoesophageal fistula and esophageal atresia, you're gonna see it from what's called milk regurgitation, right? So the tracheoesophageal fistula, the esophagus ends blindly. That's what you call esophageal atresia. You can see right, it ends blindly. That is esophageal atresia, and then the trachea is a fistula. The lower part of the trachea communicates to the esophagus. So the lower part joins the trachea near its bifurcation, right? So how do you see? Swallowed milk is regurgitated. So the baby won't be able to swallow milk. You can see because there's a blind end. So milk is going to what? To be regurgitated. So take note of this. This is going to be the most common, most common, most common, right? And there's this type and another type like this, another type like this one is the most common where you have your esophageal atresia and the tracheoesophageal fistula at the level of its bifurcation. Right. So we see it by oesophageal or by regurgitation of swallowed milk. Let's go to another one. We have a tracheostenosis and atresia. So stenosis and atresia are the result of unequal partitioning of the foregut, right, into the esophagus and the trachea. So stenosis, it just means that we have decreased caliber of the lumen of the trachea. And then atresia, there will be a blind end of the trachea, right? So that the trachea is not proceeding to the what, to the lungs or to the bronchi. There is an occlusion, right? So let's go to the development of the trachea. So remember, we said we have a respiratory bud or diverticulum right here, and then at its caudal limit is going to divide into two, forming what you call main bronchi or principal bronchi. And then the part that connects those bronchi, right, that's going to be your trachea, is it? So the tracheal bud divides into primary bronchial buds, right? That will become your main bronchi, right? The bud will grow into the pericardial peritoneal canals, right? Remember, we said the pericardial peritoneal canals, these are canals that facilitate a communication between the peritoneal cavity and the pleural cavity. Remember, so the lung will grow towards or inside or yes, inside the pericardial peritoneal canals, right? So the buds grow into the pericardial peritoneal canals, the primordia of the pleural cavities. So the pleural cavities, they are going to be formed from these pericardial peritoneal canals. Remember, right? And these pericardial peritoneal canals are the ones that are going to be closed by the pleural peritoneal membranes, those that will form the what? The diaphragm. Three, the bronchial bud differentiates into a bronchi, right? So, and this bronchi is the one that will be growing towards this pericardial cavity, pericardial peritoneal cavities, and then the bronchi is going to continue to into the main bronchi. It will it will um it will because we're going to have the left and the right main bronchi. The one of the right main bronchi, it will further divide into what we call segmental, or it's gonna divide into what we call lobar or tertiary secondary bronchi. So we have the main bronchi, secondary bronchi, the main bronchi being the primary bronchi. The secondary bronchi to the right, we're going to have a three secondary bronchi, right? That resemble the three lobes of the lung, of the right lung. Then to the left, we're going to have two um, secondary bronchi that resemble two lobes of the left lung. It's very important for you to take note of that one. Right, so we spoke of these. Right, so now let us go to the development of the lining. So you have to take note of this. You have what you call a pharyngeal arc, a pharyngeal pouch, which is a pharyngeal arcs. We'll focus more of it when we are doing the embryology of the head and neck, right? So let's go to the development of the lining. So the lining is going to develop from the what we call pharyngeal arcs. So we have the fourth and the sixth pharyngeal arc forming your linings, right? So these pharyngeal arc, they are going to be innervated by the vagus nerve branches, right? Which will innervate the laryngeal muscles. Remember the laryngeal muscles, the vocalis muscle. You remember it, right? That is innervated by the branches of the vagal nerve. We have the left recurrent. If you remember, you have the left recurrent laryngeal nerve that is responsible for phonation. Remember that, right? So the laryngotracheal tube, it produce what's called erythenoid swellings, right? So we're going to talk about it later. Uh, so these erythenoid swellings are the ones that are going to form, right, things that have to do with with your vocal cords, your vocal cords, your true, your false vocal cords that are responsible for phonation. Laryngeal epithelium closes the laryngeal lumen. So first of all, at early embryological development, you're going to have what you call a closure of the lumen by the proliferation of the epithelium of the larynx, right? And you're going to later have what's called recanalization, where we're going to canalize the laryngeal the laryngeal lumen, right, in a way that we form uh, vocal cords, right? So what is important here, the larynx, it originates from the fourth and the sixth pharyngeal arcs, while the epiglottis, it develops from the third and fourth pharyngeal arcs. Very important, right? So these are the pharyngeal arcs. You can see this is a pharyngeal pouch with your pharyngeal arcs. So the fourth and the sixth, they form your larynx. The so the fourth and the sixth, right, they form your larynx, right? Very important. And then your third and fourth is gonna form your what? Is gonna form your epiglottis. Remember the epiglottis? Yeah. All right. So malformations of the larynx. So there are two of them that are important. You can have what's called laryngeal atresia. So remember we said that we have the laryngeal epithelium that is going to proliferate and occlude, right, the laryngeal lumen. And then after occlusion is going to be recanalized. So failure of the recanalization of the laryngeal, those laryngeal epithelium is going to lead to what you call atresia, laryngeal atresia. That will cause what you call airway obstruction syndrome, right? Just imagine if there is atresia of your larynx. It means that whatever air that will be coming from the mouth, it will not go to the lungs because it is closed. The tube is closed. There is airway obstruction. We can also have incomplete recanalization of that laryngeal epithelia that can lead to what called laryngeal web. So this is just partial obstruction of the what? Of the airway. Now let's go to the bronchi, bronchus, and lung. So the bronchi, you're going to have the right and the left bronchi. The right bronchi is going to be vertical, short, and broad. The left bronchi is going to be narrow, a bit of horizontal, and long. So the right bronchi is larger than the left one, that is true, and it is vertical. So it being vertical, it means that a foreign body is more liable to fall in the right bronchi than the left, because the right bronchi, right, it is vertical, right, the left will be horizontal. So whenever you swallow a foreign body, it's more likely to go to this right bronchi because it's the one that is more broader and vertical. So foreign bodies, they are liable, they are more liable to fall in the right bronchi than the left. So the main bronchi, this is your main bronchi, right? Main bronchi or your primary bronchi, right? They are going to further divide into secondary bronchi that are called lobar, right? So to the left, you're going to have two secondary bronchi that resemble two lobes. To the right, you're going to have three secondary bronchi that resemble three lobes. And then these secondary bronchi, they are going to further divide into segmental bronchi that are also called tertiary bronchi. So in the right, you're going to have 10, which resemble what you call bronchopulmonary segments. So the right lung has 10 bronchopulmonary segments, while the left lung has 8 bronchopulmonary segments. So these are the bronchi that will be going to those segments. So they are called segmental or tertiary bronchi. So each lobar bronchi undergo progressive branching. And as they are branching into further generations, They'll be decreasing in size whilst they are also increasing surface area. So you can clearly appreciate here. So this is your right and left, right primary bronchi, left primary bronchi. The right primary bronchi is going to give it three secondary bronchi. You guys understand? Three secondary bronchi, right, or three lobar bronchi, and two to the left, two secondary bronchi. So these are the ones that are going to form the anterior lobe, the superior lobe, the mid lobe, and the inferior lobe of the right lung. And then you're going to have the superior lobe and the inferior lobe to the left lung. Right. So you can now clearly understand, right? This is going to be the right cranial lobe or the superior lobe, the mid lobe, the caudal lobe, which is the inferior lobe, the left cranial lobe, which is your superior lobe, and the left caudal lobe, which is your inferior lobe. So the left lung is two lobes. That's how you differentiate it gross anatomically from the right. The right is three lobes, right? So you're going to have your oblique fissure and your horizontal fissure, whilst your left you only have your oblique fissure. Remember. So respiratory bronchi develop prenatally and postnatally. Very important, right? So you're going to find that the lung is not go when the baby is born or at birth, the lungs are not fully matured. So the alveoli and the branching off of the bronchioles will continue up until 10 years, postnatally. So the surrounding splanchnic mesoderm, what is another name of splanchnic mesoderm? That is visceral mesoderm, that will be surrounding your gut tube, remember. So this splanchnic mesoderm is going to give rise to the bronchial cartilage plates, smooth muscle, connective tissue, and capillary. But as for the epithelia is going to come from the endoderm of the foregut. That is most specifically, that's your foregut. So the surrounding splanchnic mesoderm provides the bronchial cartilaginous plate. Remember, the main bronchi is going to have a circular cartilaginous plate, but the trachea is going to have C-shaped. And then the bronchioles is the secondary bronchi, they are going to have irregular cartilaginous plate. Remember. So the splenopubic mesoderm also determines the branching pattern on the lung buds. Very important, right? So you're going to have the endoderm of the respiratory system. Regionally, it is regionally non-specific, and it will be coming from, it will be forming your epithelia that will be surrounding your respiratory system. So what kind of epithelia is found in the respiratory system? Remember, we have ciliated, pseudo-stratified, columnar epithelia. So all the epithelia in the respiratory system is going to come from the endoderm. But the connective tissue, the bronchial cartilaginous plate, which will be your hyaline cartilage, your smooth muscle, as well as your capillaries, they're going to come from your splanchnic mesoderm. Very important, right? So the lung, remember we said that the lungs, they are growing into, right? So you can clearly understand that this is going to be your pericardial peritoneal canals at the other side of the foregut. And the lung is going to grow caudally, laterally, and ventrally, filling into the pericardial peritoneal canals. So this layer of the peritoneal so remember, the pericardial peritoneal canals, they are going to form, are the ones that are going to form the pleural cavity. So the layer that will be the layer of mesoderm that will be surrounding your lung as it invaginates into these pericardial peritoneal canals is going to be called the visceral pleura. The visceral pleura. And the ones that will be lining the body wall, this one is going to be called your parietal pleura. So between the parietal pleura and the visceral pleura, you're going to have your pleural cavity. And your pleural cavity is going to have pleural fluid that is going to be secreted by these serous membranes. So the cells within these visceral pleura, right, they're going to differentiate to form what you call serous cells. These serous cells are the ones that will be secreting a fluid that will be within this cavity called pleural fluid. So most likely, or most of the fluid, it is secreted by the parietal pleura, because in the parietal pleura you have a high hydrostatic pressure than the visceral pleura. You understand? Uh, so you have about 5 to 10 mils of fluid that will be found within this space. Very important, right? So you can now see this is your visceral pleura, this is your parietal pleura, this is your pleural cavity. Understood, right? Good. So if we are to cut cross-sectionally, if we are going to cut here like this, you're going to see that this yellow saccular structure is going to be your epithelia. And you said your epithelia is going to come from the endoderm. The ciliated pseudostratified columnar epithelium, goblet cells as well. So the epithelia and the glands that will be secreting mucus, they are going to come from the endoderm. So endoderm give rise to the epithelium and the glands. Remember. But the muscle, the cartilage, the smooth muscle, the hyaline cartilages, right? The connective tissue, the blood capillaries surrounding your gut, your respiratory system tubes, they are gonna come from the splanchnic mesoderm. So it gives rise to connective tissue, muscle, and cartilage. So you can now see this is gonna be the lumen of the trachea. This yellow, orange, circular structure is gonna be your epithelia coming from the endoderm, and there is gonna be irregular. There's gonna be C-shaped cartilages, right, and smooth muscle. They'll be coming from the splanchnic mesoderm, right. So now this is now a cross section of a bronchi, right. So how do you see? You see abundance of smooth muscle, and there's gonna be irregular folds of the lumen because of these smooth muscle, and you're gonna clearly appreciate irregular rings of cartilage. You can see a hyaline cartilage, irregular rings of hyaline cartilage, the smooth muscle, as well as the connective tissue that is surrounding, coming from the splanchnic mesoderm. And this is going to be your epithelium, your ciliated pseudostratified epithelium, right? You can see this histological slide very clearly. So this is going to be your ciliated pseudostratified epithelia right here. This is going to be your smooth muscle. You can see your glass-like appearance of the hyaline cartilage. You can clearly appreciate. And then there's going to be blood vessels. We cannot see clearly, but there's going to be blood vessels and connective tissue coming from the splanchnic mesoderm. Right. So lung maturation, it is involved in 4 processes, or it has 4 periods. Very important. So we have pseudoglandular period, canalicular period, terminal sec period, and alveolar period. You have to understand this, right? So pseudoglandular period, that's the first one. So this is between 5 to 16 week. 5 to 16 week, right? That is your pseudoglandular period. So at the pseudoglandular period, you have the branching of your bronchioles up to the terminal bronchioles, not the respiratory bronchioles, right? Very important. The pseudoglandular says. And there are no alveolar sacs formed. Alveolar sacs are going to be formed later on. But in the pseudoglandular period, you're not going to have all those things. So lungs major elements are formed except the gaseous exchange tissue. That is going to be your respiratory bronchi, your alveolar sacs as well as your alveoli. They are not yet formed. So respiration is not possible. So take note of this. Fetus born at this period of development will not survive because the respiratory system is not functional. So if a fetal or a premature baby is going to be born at weeks between 5 and 16, that fetus will not live. Right. The canalicular period. Now, when you are now at the canalicular period, you now have the bronchi, your terminal bronchi. They are now further dividing into what called respiratory bronchi. So there is a formation of respiratory bronchi. That is the most important thing. You understand? So they are called the respiratory bronchi because they are going to form, or they are going to have, each respiratory bronchi is going to have about 3 alveolar sacs. So therefore gaseous exchange is now possible. You understand, right? Uh-huh. So bronchi and terminal bronchi lumen enlarges vascularization of lung tissue. So that's where in how you're going to have the interaction of your endothelium and your endothelium and your epithelium of your alveoli for to form what called blood-air barrier, right? So now we have the formation of the respiratory bronchi. Like I said, there's now increase of alveolar ducts, right? Respiration is possible at the end of this period. So this period is from the 16th week to the 26th week. That is your canalicular period, right? Then uh, terminal, um, okay, sorry, you're going to have these what you call primordial alveoli, right? That will be formed from these respiratory bronchi. And take note of this: a fetus born at the end of this period dies. Other systems are immature, right? So why? Because we haven't formed what you call uh, the alveoli, the primitive alveoli, that will produce surfactant. So the fetus is not uh, yet in a possible position for it to breathe because some of the structures of the respiratory system are not fully developed. Right, so you can clearly see, right, the canalicular period. So this is your terminal bronchi, right? So that was going to be your pseudoglandular, your terminal bronchi, right? When your terminal bronchi differentiate or divide, further divide into respiratory bronchi, you're gonna form. Now we are in the what? Canalicular period, 16 to 26, like I said. And then that's where you now have vascularization of your respiratory system. You can see now these blood vessels, they are now blood capillaries are now communicating or interacting with the epithelia of your respiratory system, forming the blood air barrier. Now we go to the second last, the terminal saccular period. So the terminal saccular period, right, the very important period, right? Why? Because we now have the saccus, right? They would develop a thin epithelia, right? So you now have your alveoli, you now have your primitive alveoli, and then they are gonna form, right? They are gonna its epithelia is gonna be thin, right? It's gonna be squamous, and it's gonna have two types of cells, what you call type 1 pneumocytes and type 2 pneumocytes, right? So you also have a capillary bulge into the lumen of the alveoli. Blood air barrier permits adequate gases exchange, right? And then these terminal circulars are lined by squamous epithelial cells. These are called type 1 alveolar cells or pneumocytes, which will permit gaseous exchange. So you're going to have two kinds of cells lining your alveolar surface. You're going to have type 1 pneumocytes that are going to be squamous, right, or flat. These are the ones that are responsible for gaseous exchange, right? And they occupy about 97% of the surface area of the alveoli. And then you're going to have type 2 pneumocytes. Type 2 pneumocytes, they are not responsible for gaseous exchange, but rather they are responsible for secreting a substance that is called surfactant. And these type 2 are the ones that are mitotically active to replace the type 1. And they are cuboidal in structure. You understand? So a baby, a fetus born at the terminal saccular period is going to survive. Why? Because the gaseous exchange is possible and we now have the formation of surfactant. Right. So the capillary network is going to proliferate because we are forming the blood-air barrier. Then the type 2 alveolar cells or pneumocytes, they secrete what you call pulmonary surfactant. So pulmonary surfactant, it's a uh, phospholipid secretion that is responsible to lower the surface area, the surface tension at the air alveolar interface. You understand? So surfactant, it prevents the collapsion of your lungs or of your alveoli, right? After expression. So when expression occurs, right, you need to prevent the col, col okay. So you need to prevent the collapsion of your of your alveoli. So you need the surfactant to lower the surface area. Remember, when surface area is lowered, right, you're going to prevent or you're going to reduce pressure, right? So when you reduce pressure, you're going to have your alveoli open. They must not completely close. You understand? Uh-huh. So production of surfactant increases during the terminal stages of pregnancy, right? The terminal saccular period. And surfactant is also important to initiate birth or labor. So it increases at about 2 months before labor. That's where surfactants start to increase because it is important to it is important to initiate labor, and it is important to lower the surface tension of air alveolar interface, right, to prevent the collapsion of your alveoli. Pulmonary surfactant counteracts surface tension and facilitates expansion of the terminal saccules. That's your primordial alveoli. Surfactant deficiency causes what you call respiratory distress syndrome, right? So it's very important to take note of this. So absence of surfactant, you're going to have respiratory distress syndrome. Surfactant is adequate in the late fetal period. We say this. Before this, the lungs are incapable of providing adequate gaseous exchange. You have insufficient alveolar surface area, and there is underdevelopment of vascularity. So surfactant is very important. Adequate pulmonary vasculature and sufficient surfactant are critical for fetal survival. So that's why we say in canalicular period and pseudoglandular period, you don't have the survival of a fetus. Now let's go to alveolar period. So remember those terminal sac, right? They're going to be lined by an squamous epithelia that we say type 1 pneumocytes, right? And these type 1 pneumocytes, they're also called type 1 alveolar. They become thin, right? And there's going to be interaction between this epithelia with capillaries, forming what you call the gas, the blood air barrier. So late fetal period, the lungs are capable of respiration. You understand? So replacing placental gases exchange to lung gas exchange requires the following lung changes. So these are changes that are important for lung gases exchange. One, we need adequate surfactant in the alveoli produced by type 2 pneumocytes. B, lung changes from secretory to gas exchange, right? Then three, presence of parallel pulmonary and systemic circulation. So vascularization of respiratory system is essential for gases exchange, right? So you can now see there's now complete vascularization. You can see interaction. You can see this blood. This is a blood air barrier here, a blood air barrier here, a blood air barrier here, and you can see this connective tissue is gonna be having your fibroblast, and it's gonna have elastic fibers. You can see these elastic fibers that are very important for the recoiling of your lung. Lungs after birth. So maturation of 95% of alveoli. So about 1 over 6, you have about 1 over 6 of alveoli present at birth, which means 7 over 6 alveoli, they mature after birth. You understand? Respiratory bronchi and primordial alveoli, they increase in number. So there is hyperplasia, right? Hyperplasia and the hypertrophy of these alveoli in the postnatal period. Increase of the surface of the air blood barrier. This increase is due to multiplication of alveoli and capillary. About 50 million alveoli are present in the lungs of a full-term newborn, right? Very important, very important, very important. So newborn infants, the lungs of infants, due in radiography, they are going to be more dense than the adult lung. More dense than the adult lung. You understand? So at birth, you're going to have about 50 million, and then later on, the, the total alveoli that will be present after 10 years is going to be 300 million alveoli. 300 million alveoli will be present. Okay. So let's talk about breathing movement, right? So you need to understand that it occurs before breath. The movement of breathing, it occurs before birth. It doesn't start after birth. So it is done before birth. It is done by exerting force to cause aspiration of amniotic fluid into the lungs. So you're going to have fetal breathing movement present before birth. Very important, right? And this breathing movement, they are essential for lung development. For the lung to develop, you need this breathing movement to take care to occur before birth. So at birth, the lungs, they are filled with fluid, because like the remember during during at, before birth, the fetus will be swallowing, right, or breathing in and breathing out amniotic fluid. So at birth, the lungs will be filled with amniotic fluid, right? And the amniotic fluid will be derived from three. You're gonna be derived from the lungs, the tracheal glands, as well as the amniotic cavity, obviously. So lungs aeration at birth is by replacement of intra-alveolar fluid by air. So you're going to have the removal of this fluid, right? So what are the three routes of the removal of the fluid? One, mouth and nose by pressure of the fetal thorax breathing delivery. So some of the fluid is going to be vomited out. And then second, some of the fluid is going to be taken by the circulatory pulmonary capillaries, and then it's going to be drained into this lymphatic system, right? And then lymph flow is rapid during the first few hours after birth, right? And then it diminish in order to empty the lungs, right? To give the lungs space for air, for gaseous exchange. So what are the factors that affect normal lung development? One, adequate thoracic space for lung growth. So you remember we said um, in development of body cavities, there is what you call congenital diaphragmatic hernia, where we say that you have the failure of closure, about 90% of your left pericardial, pericardial peritoneal canals, right? And then you're going to have your abdominal viscera getting into your thorax. And if there is limited pressure in the thoracic space, and then we say that there is a lung hypoplasia. So there is a failure of complete development of the lung because the thoracic space is limited. And then you need fetal breathing movement, and then you need adequate amniotic fluid volume. Very important, right? So the lungs of a newborn, right? So healthy lungs contain some air, definitely, right? And then pulmonary tissue will float in water, right? So these are the characteristics of a healthy lung. But a diseased lung, it will not float in water, right? It will not float in water. It will be denser than water. You understand? So lungs of a stillborn infant or a dead infant, right, are are firm and they sink in water because they contain fluid, not air. So if the infant is born dead, it means that we don't have the activity of the pulmonary capillary to absorb all the fluid into your lung, right, and get the fluid in the lymphatic system. So the lung is going to be dense. That's why we say it radiographically, the lung of a newborn is going to be denser than the lung of an adult. Let's go to the clinical context. So we spoke of the respiratory distress syndrome. That I said it's due to the insufficiency of surfactant. So surfactant deficiency is a major cause of respiratory distress syndrome, right? Lungs are underinflated, right? Alveoli contain fluid with a high protein content, right? And so the way to, if a child is born with respiratory distress syndrome, we are going to give an exogenous surfactant, right, in order to reduce the severity of the respiratory distress syndrome. So these are other congenital disorders. You can have congenital lung cysts that will be developing within your lungs, right? Uh, Remember, these bronchi, when they are dividing and dividing, they may form cysts in the lung, right? So these cysts will be filled with fluid or air, but there will be no gases exchange taking place at that area, right? So you can have agenesis of lungs, which is failure of development of lungs at all. You can have failure of bronchial buds development. You can have lung hypoplasia, especially in congenital diaphragmatic hernia. right? In congenital diaphragmatic hernia, interference with the lung development due to pressure of what? Of these abdominal viscera. So there's a lung hypoplasia, right, which is reduced lung volume, right? So thank you so much. This is everything about the development of the respiratory system. Thank you so much and take care.